Good afternoon, everyone. Bancroft Neuro Rehab welcomes you to our Heads Up webinar series. For those of you unfamiliar with Bancroft Neuro Rehab, we are a premier provider of post-acute neurologic rehabilitation, offering residential and day services, neuropsychology, and outpatient services at 3 locations throughout southern and central New Jersey: Mount Laurel, Plainsboro, and Toms River. Bancroft Neuro Rehab is a division of Bancroft, a provider of programs and services for individuals with autism, intellectual disability, and other neurological conditions. Today's program is Vestibular Rehabilitation. What's the spin? We'll have time at the end of the presentation for Q&A. And now I will turn the presentation over to today's speaker, Dr. Carolyn Tassini, who is a rehabilitation supervisor at Bancroft Neuro Rehab and a board-certified neurologic physical therapist.
Hi, everybody. Thank you for joining. As Stephanie said, my name is Carolyn Tassini, and I am the physical therapy and occupational therapy rehab supervisor at Bancroft Neuro Rehab in the Mount Laurel location in South Jersey. So my background is that I actually started my career in acute care. I was also a certified athletic trainer. And I then moved down to Moss Rehab outside of Philadelphia, where I completed my neurologic residency, worked in inpatient rehabilitation, and became the supervisor there before coming to Bancroft Neuro Rehab and working as a PT and supervisor at our South Jersey location. But what's really interesting is that no matter where I was working, whether it was acute care or on the athletic field, or in an outpatient setting or an inpatient setting, one of the diagnoses and some of the challenges we saw frequently were individuals who had vestibular deficits. So what's really cool as a therapist treating vestibular rehab is that it doesn't discriminate as far as setting. You can see it no matter where you're working. And on a personal level, it's hit my personal life in that both of my parents have had vestibular issues as well. And so we've been able to work through that. So today, I'm trying to advance a slide here. Okay. I do have nothing to disclose today. But in today's session, we're really going to be doing a general overview of vestibular rehab and our vestibular system. You know, for therapists on board who treat this is going to be really, really basic. But for the rest of folks, I want to give you an introduction as far as what is the role of the vestibular system and what does it look like when our system is not working efficiently or effectively, and what can vestibular rehab do for individuals who have impairments. All right. So let's talk about this vestibular system. Our vestibular system is a relatively small system with some big connections. It's made up of 2 parts. The first part is our peripheral vestibular system, which is located in here in the inner ear. So the peripheral vestibular system is made up of 3 semicircular canals, 2 otoliths, which are called the utricle and the saccule, and our 8th cranial nerve. And that all makes connections out to our brain and all those connections out that way. And that's our central vestibular system, which is made up primarily of that vestibular nuclear complex and the cerebellum. So what does this system do? First of all, it helps us with gaze stability. And this is where we're working on maintaining our eyes on a target, especially while we're moving. So as you're walking, or turning your head, your eyes in a normally functioning and healthy functioning system will remain stable. But for people that have a problem with this, their eyes can be bouncing around as they're moving in space, and this can cause real deficits for them and contribute to some balance and instability. It also works on postural control. The vestibular system has both this motor and sensory components, and they work alongside and in partnership with our vision and with our somatosensory, which is kind of our sensation or proprioception, to help us with our postural control or balance and ability to make corrections. It helps with motion detection. So our vestibular system will sense acceleration, and it can do this in both linear patterns, and that's picked up by those otolith organs, and the rotational movement, which is picked up by our semicircular canals. And lastly, it helps with orientation in space, which is kind of helping us orient our head vertical relative to gravity. So with those being the things it does, it's probably not too surprising then that if people have dysfunction within their vestibular system, it includes things such as disequilibrium or imbalance or unsteadiness, and this could be with walking, stairs, any kind of functional activities. They can have symptoms of abnormal motion, that feeling of dizziness or vertigo, or oscillopsia, that's that eyes moving around piece, and some postural instability. They can have motion sensitivity, where even small movements of their head or even the world around them can cause them to feel unstable. It can make them feel nauseous. Again, not having a stable visual environment, the world bobbing around them, and ataxic gait, or that unsteady gait. And you can see how these issues might really impact someone's ability to read or to drive or to walk around or do their ADLs or return to work or take a shower, pick up their children. A lot of different activities can be impacted by these kind of dysfunctions. So this is a video here of, and it is grainy, it's not you, but it's oscillopsia. And this is that term for when a person has trouble maintaining a stable gaze. So where you or I could walk through an environment and not have and be able to maintain a smooth sight of vision, these individuals, as their world moves around them, they get this jostling feeling. And imagine what that would feel like if you were living your life that way. All right, so let's talk a little bit more about how these systems work. So our peripheral vestibular system, this is that piece that's located in the inner ear. It's divided into a bony labyrinth and a membranous labyrinth. The bony labyrinth is housed within the inner ear, and it's bordered laterally by the middle ear and medially by the temporal bone. It's this peripheral vestibular system and peripheral vestibular apparatus that contains the 3 semicircular canals, the cochlea, and the chamber between the two. So it has our hearing component as well, but we don't worry about the hearing piece right now, just the piece that can work on that gaze stabilization and dizziness. So when you see where it's housed in here in this inner ear feature, you can see how someone who might have a temporal bone fracture, maybe from a fall, could also damage this peripheral vestibular system. This is in fact what actually happened to my father. So he had a fall and damage to the system that way. Now inside of that bony labyrinth, as you can see kind of in the blue here, is our membranous labyrinth system. And this is suspended within that bony labyrinth, and it's filled with this endolymphatic fluid. This is here where we've got those sensory organs, the canals, the otolith organs, which are the utricle and saccule. All right, we're going to dig in a little bit more on this. So in both our semicircular canals and the otolith organs, we have hair cells, and the hair cells are really what generates the activation. These are what convert the movement into a neural activation and cause the excitement. In our canals, those hair cells shoot up into this cupula, and they are moved around by the fluid that moves through these canals, because there's fluid floating around in here. In our utricle and saccule, we have our hair cells that shoot up into this gelatinous membrane here. And on top of that sits these otoconia, which are these calcium carbonate crystals. So because of the way these guys are oriented, the semicircular canals, again, these guys up here that have fluid moving around them, they're sensitive to angular acceleration. And our otoliths that are sitting here with a little cap of crystals on them, they're sensitive to gravity and linear acceleration because they have that weighted system on them. To clarify those semicircular canals a little bit, there are three. There's an anterior, a posterior, and a horizontal. And what's really cool about our system is that they exist on either side, so by either ear. And they kind of have this push-pull system, right? So if you look here and you've got your anterior semicircular canal, which goes out on this angle here, and your posterior semicircular canal, which goes down here, you can see how they work opposite of each other. So if you excite this left anterior, you inhibit this right posterior, and that's how you have that push-pull. But you'll see where things start to go wrong in these individuals is that if one side is working well and the other side is not working as well, you've got an asymmetry in that push-pull. And this is kind of where some of our systems start to fall apart. So we take all that information from that peripheral system and also information going out to the peripheral system, and it goes into these central projections. Now these are huge. There are many, many, many projections. I'll kind of share a little bit more about them on the next slide. But essentially, it's our central system kind of has two major complexes that work for us. One is that vestibular nuclear complex. And this is really where we get the processing of vestibular input. It makes these direct and fast connections from the system out to our motor neurons, so we can make reactions. And then the cerebellum, which does a little bit more of our adapting processing. So this guy monitors our performance, our vestibular performance, and can adjust the responses and processing if needed. So when we look at these systems, this peripheral system, which has our semicircular canals and our otolith organs and our vestibular nerve, and we have our central nervous system, which is that vestibular nuclear complex, and all of those different pathways that come out of it. When we have an injury or damage at any point in any of those systems, we can end up with vestibular deficits, as I talked about earlier. All right. So how often does this thing happen? Well, dizziness alone really accounts for nearly 7 million doctor visits per year in the United States. It's a common complaint in our medical environment, being the third most common symptom presentation when combined with imbalance and falls for outpatient medical consultation. And this follows behind chest pain and fatigue. In our adult population, 42% of individuals will report dizziness at some time in their life. Dizziness can be found at any age group, but the frequency does increase with age, at least the frequency of that complaint. It's actually one of the main reasons for visiting a doctor after the age of 75 years old. In addition, people who have dizziness issues or these vestibular problems have a 12-time greater risk of falling than those without these deficits. All right, so I have to scold myself here a little bit because I use this term dizziness because that's kind of what a lot of people use when they come in, and any therapist on the call is going crazy because they're like, well, this is dizziness, right? So people come in, they say they feel dizzy. You know, when my mother called me up not feeling well, and she said, I feel dizzy, but I think it's just my allergies. Well, dizziness is really a vague term that people use, and generally they use it to describe a sensation of movement or feeling unsteady. So as a therapist, one of the first things I do is I ask the person to tell me, to describe what they're feeling without using the word dizzy. So frequently what comes up are terms like vertigo, and that's that sensation of movement or spinning. The world is spinning around them or they're spinning, twisting, turning, rocking. Then there's that, some people might say, yeah, I feel lightheaded. I feel floaty or woozy, uneasy. And then there's people who feel disequilibrium or imbalanced. They feel unsteady. So it's interesting and important for us to kind of get an idea of what exactly is it that this person's feeling, because there's different presentations for different syndromes. Now, there's lots of different things that can go wrong with our vestibular system and its connections. If we look at our peripheral vestibular systems, we can either have a hypofunction, which means that one of the systems is not working at full capacity, or it's not working at all. It could mean that both of the sides are not working at full capacity or not working at all. So there's a unilateral or a bilateral hypofunction. We could have distorted signals rather. And that's something where this is like a BPPV, where you're getting a signal that really coming from a system where it really shouldn't be coming from. And then there's fluctuating function, where those symptoms kind of come and go. We have our central vestibular disorders. These include causes can be stroke, brain injury, tumor, demyelinating disease, neurodegenerative diseases, anything that really is impacting our central nervous system. And people can also complain of dizziness due to cardiogenic origins. You've got your orthostatic hypotension, right? Or people that are generally hypotensive. And then medications. You can't catch a commercial on TV these days without dizziness being listed as a side effect of medications. So we're just going to talk briefly about a few vestibular pathologies. And again, this is not a comprehensive list because there's a whole lot more that can cause this, but we're going to spend some time talking about benign paroxysmal positional vertigo. And from here on out, I will call that BPPV because that's a mouthful. Vestibular neuritis and labyrinthitis. Meniere's disease. We'll talk about bilateral vestibular loss and central vestibular disorders, just briefly. All right, so BPPV. I put its long name in there for you. Benign paroxysmal positional vertigo. This is the most common cause of vertigo for individuals. It's about 17 to 42% of individuals who have vertigo actually get this diagnosis. What happens with these guys is that the otoconia, so remember these calcium carbonate crystals, that were sitting on top of that gelatinous mass that house those hair cells coming up, one of those crystals or a few of those crystals come loose. And these crystals become free-floating debris and they get into the semicircular canals. So the crystals are great when they're sitting here on the utricle and saccule. They're really fantastic. That's where we want them. But when they drop loose and they end up into our canal system that just had fluid moving through it before, because remember the way that that made its flag move was by the fluid displacing the cupula, you now have a system that is sensitive to gravity because you've essentially taken a rock and thrown it in a tube, and it's delaying it's distorting that signal, and it's changing the frequency and the timeliness of the response you're getting. So the result of this is positional dizziness, because as that person puts their head in a position and that rock moves, they're dizzy in that period of time when that rock is moving. And when it stops, when it settles down, you're not dizzy anymore. So typically these guys are dizzy for usually about 20 to 30 seconds, and then they feel fine until they move their head again, which moves that calcium carbonate crystal or that rock again. Way more complex pieces of this because it could also be stuck to different things as opposed to just moving through the canals, but that's beyond the scope of this talk today. So the way this is diagnosed is that we use the Dix-Hallpike maneuver. So the Dix-Hallpike maneuver is a positioning test where you take the patient and you hold their head, you bring them, turn them to the side of 45 degrees, and you extend them back over with 30 degrees of extension of the neck. And while you have that person in that position, the therapist is looking to see what's going on in their eyes. So in this video we're seeing here, we're looking at, they're showing us a beating and torsional nystagmus. There are also horizontal nystagmus that you can see, or straight vertical nystagmus. And all the different directions we see give us an idea of where that, what's going on, where the debris is, or what the issue might be. In real time here, this is actually a real video. These are from the Vestibular First goggles. So again, this is a patient's eyes. They move them into that position. We have them open their eyes, and you can see the actual eyes moving. And we use the movement of the eyes and the torsion, direction of torsion, to make the diagnosis. All right, so that's BPPV. The next thing we're going to talk about is vestibular neuritis. This is caused by irritation or inflammation of the vestibular nerve, so out here, okay? Oftentimes, there is an infection that will precede a case of vestibular neuritis. Usually that infection is like a GI or an upper respiratory tract infection. We see this in peak in ages 30 to 60 years old. They don't typically have hearing loss because this hearing portion, this cochlea, is all okay. Their symptoms usually go away after about 48 to 72 hours, but they will have ongoing imbalance and disequilibrium, which gets better over a period of time, usually several weeks, 6 or 8 weeks or so. For the therapist, when you do that evaluation, you'll see a spontaneous onset of vertigo. It's oftentimes quite severe. You'll see nystagmus, horizontal nystagmus that's beating towards the good ear. They are often quite nauseous, and they have oscillopsia, or that bouncing vision, and impaired balance. So that is vestibular neuritis. And so when one thing to think about is, as I said, this is often preceded by a viral infection. This is something that is showing up in some of our individuals who are post-COVID. Labyrinthitis, similar, but it's where you have an infection of the labyrinth of the inner ear. So now our inflammation is in this area as opposed to the nerve. So very similar to vestibular neuritis, you're still going to have all that dizziness, the acute bout, imbalance. But in these guys, because the labyrinth is involved and our cochlea and all of our hearing features, they'll oftentimes have hearing involvement as well as tinnitus. So Meniere's disease is a fluctuating presentation. It is associated with an accumulation of endolymphatic fluid in our cochlear duct and our vestibular organs. But it's interesting because this really doesn't totally explain all the clinical features we have. These individuals will have attacks that can last anywhere from 30 minutes to 24 hours. And those symptoms are going to slowly go away, but then they're going to feel imbalanced again for a few weeks. We see this most oftenly in individuals in their 40s to 60s, but it has been reported in some children. It usually starts unilateral, so in one side, and as the individuals have repeat cases of or bouts of Meniere's, it can actually get progressively worse in that side, and oftentimes it will become bilateral. It's fairly rare, but you can see it. For symptoms, like they're gonna have this sensation of fullness in the inner ear. They'll have hearing loss, tinnitus, the vertigo, nausea, postural imbalance. You'll see nystagmus, that sensitivity to movement. As far as vestibular rehab goes, we don't use it during an acute attack, but it can be used in between attacks. So a person has an attack, then they start feeling better. So you could see them in between, but really you want to be seeing them for it if they have some long-term hypofunction, and trying to get that system online and running a little bit better, because there is a general return to normal after a few weeks. But again, the more attacks they have, the more this impacts their system and ability to return back to normal. So then there's bilateral vestibular loss. So our Meniere's disease and our neuritis, our vestibular neuritis, these kind of start more of a unilateral vestibular hypofunction. In this case, we're going to talk about bilateral vestibular loss, or even a bilateral vestibular hypofunction. This is something that can be caused by different medications. So like gentamicin is a big medication for it that can impact this. Any diseases of the like central nervous system, like a meningitis, might cause a bilateral vestibular loss. Some chemotherapies might impact this. What's really cool is that if a person, not for them, but if a person has a bilateral vestibular loss, right? So the systems are both down on both sides, they're actually not dizzy because there's no mix of signals. They're both down flat, or they're both hypofunction together. So if there's symmetry within those the systems, they're actually not going to be vertiginous. That said, though, they will have oscillopsia, which is that impaired gaze stability. They'll have impaired balance, especially when they're have to rely on that vestibular system. And that means environments where it's really dark or they're on a compliant surface. Or in the pool. In the pool, these guys really have trouble orienting towards vertical. And these guys might complain of lightheadedness, and you'll frequently see an ataxic gait in these. Again, this, so medications might cause this. Someone who has a progressive bilateral neuritis might end up causing this eventually. A few different things that may contribute to this. And then for central vestibular disorders, these guys are, the clinical presentations is so widely varied, and that's because of the myriad of locations that can be impacted and cause symptoms. So if you had someone with a brainstem stroke, that's going to present differently than someone with a posterior fossa tumor or posterior fossa stroke. And so the clinical presentation is going to be quite different. When people have central vestibular disorders, they might have other signs of central vestibular dysfunction. So if you see someone come in, they've got dysarthria, diplopia, dysphagia, dysmetria, any of those are big red flags. You want to make sure you're sending them to the doctor, unless they've already been to the doctor and the doctor knows, yes, they have a known central deficit. Again, with these guys, when we look at the nystagmus, which is that ways those eyes are moving, when we see a pure vertical nystagmus, that's a red flag for a central vestibular disorder. And when we're doing examination in these individuals, we see that they can have impaired smooth pursuit, which is the ability to keep your eyes on a target while it's moving around. So as you're looking around, say reading or tracking, an airplane is flying over my house now, so for me to track that airplane with my eyes, or saccades, which is, and you can see saccades, which are the inability to, when your eye adjusts targets, that it might jump off of it and take a few beat correction before it gets onto its focus. And they might also have complaints of double vision. And then we have other non-vestibular pathologies, which these are other conditions where the person might complain of feeling dizzy, but not necessarily have true vestibular issues. These can be migraines, can make people feel this way. There's cervicogenic dizziness. This is really interesting. This is a whole other talk on its own. And this is where people can get this dizzy feeling from the mechanoreceptors in the neck. This is something we see quite a bit after auto injuries or like whiplash injuries. People that have peripheral neuropathy can end up with vestibular symptoms. Orthostatic hypotension or vertebrobasilar artery insufficiency, anxiety, that's a red flag right there. A lot of people, anxiety is something where people can really cause this feeling of dizziness when it's just this anxiety that's internal to them. Along those lines, people that have dizziness can oftentimes have anxiety because they don't feel great. And so these kind of perpetuate each other and can be a challenge. Pharmacology, like I said, all those medications that you watch TV and everything is can make you dizzy. So some of the bigger drug classes that can do that would be like our pain meds, some cardiac meds, like your hypertension meds can do it, some antibiotics, antidepressant meds, even some anti-anxiety medications can do it. And then obviously some of our sedatives and some chemotherapy can induce these feelings. And then the other kind of piece of non-vestibular pathology is COVID-19. So this is new to us, right? You know, we've been dealing with this for about 1.5 years, but what we're seeing is that some individuals who have COVID-19 are presenting with complaints of dizziness. And it's generally a generalized complaint of dizziness. So we know COVID-19 is generally a respiratory illness. And you can see that mild respiratory involvement to severe pneumonia. But you might also be aware that there are some patients that are presenting with neurological symptoms. And these are really diverse. They can go anywhere from a loss of consciousness or a decrease in consciousness, people complaining of headache, and then you've got people complaining of dizziness. And it's not super clear what's causing the dizziness or imbalance in this population. It's seen in those long haulers. So if you have someone who's had COVID, and oftentimes long haulers are individuals who had more of a mild case up front, but they're dealing with these symptoms long term, and they're complaining of, feeling off balance, feeling uneasy. And so again, relatively new illness, so we're not sure exactly what's going on. They think it might be related to some of the neural tissue invasion. We know that COVID-19 has a hypercoagulability piece to it, and that's part of why it's causing some strokes as well, or some vasculitis. And any of these things might influence our central nervous system and create this dizziness feeling. In this study by Tan, they took a look at changes in the audio vestibular system, so not just our vestibular imbalance, but also hearing. And they found for these guys that they have a decreased gain in the head shake test, which is kind of a VOR, a vestibular test. But they also have hearing changes, hearing loss at these high hertzes, 4,000 hertz and 8,000 hertz. Like I said, what these folks are generally seeing are dizziness, general dizziness. So it's not that vertiginous, it's that kind of that general dizziness feeling. And they see that to 1/5 of individuals with who've had COVID-19. And then of course our medications, as we talked about, so there were medications that can be ototoxic. Well, some of the meds that we're giving out for COVID-19, like azithromycin and hydroxychloroquine are ototoxic medications, so they could be contributing to this presentation. In this study by Viola, they looked at tinnitus and equilibrium disorders again. So similar are individuals who had vestibular disorders was in that 18.4%. And within that, 94% of those guys complained of dizziness, while there were a smaller amount, about 6%, that were complaining of acute vertiginous attacks. As we look at the literature and it changes in our COVID-19 world, we're also seeing that there are some cases of people who are presenting to the ER with their initial symptoms of dizziness. And so that could be potentially a potential warning sign that someone might have COVID. But again, these are smaller case studies. All of this stuff is so new and just kind of continuing to develop as we learn more about this disease process. So here's the deal. These people have all these issues, so what are we supposed to do with them? Well, thankfully, there's vestibular rehabilitation or vestibular balance rehabilitation therapy. And our goals are to decrease a person's imbalance or disequilibrium. We want to try and decrease their oscillopsia or improve their ability to maintain a steady gaze. We want to work on balance, functional balance, help them with the activities that they weren't able to do before. Improve that ability to see clearly while there's head movement or body movement. We want to improve overall conditioning, and that may sound strange, but this is because when someone has dizziness problems, oftentimes they start really limiting their activities because they feel crappy and they don't want to move. And so they're sitting around because moving is a nightmare for them. So we need to get them overall health and condition better. We want to help them return to their life roles, whether or not that's a student, maybe that's as a parent that needs to care for their children, or a grandparent, or even ability to go out and mow your lawn or take your garbage out. And we want to reduce social isolation. Again, when these people feel lousy, they don't go out, and we want to help them feel better and also give them strategies so that they can be successful and go back out into the world and feel better. Real general as far as some of our rehab approaches. So we do gaze stabilization exercises, and this is some activities that we use to work on restoring the gain of the VOR, meaning that we want it to be 1-to-1. We want both sides firing evenly. So if one side is firing a little bit less, we want to increase that gain so it's back even with the other side. Now, for anyone that's been around for a long time, you may have used those terms adaptation and substitution exercises. They used to be considered their own groups, but now they're lumped together under this title of gaze stabilization. So just as a, if you're doing some literature searching, you might find people, older literature, and not even that old, looking at adaptation and substitution, but these are all gaze stabilization. And this is really in light of some of the recent evidence that's come out about the mechanisms of how this works and how it impacts function. So gaze stabilization really kind of has like three main exercises, and there's progressions that we do of them. And so number one is maintaining your eyes on a target while your head rotates side to side. Number two is moving between targets. So your eyes and head are on a target, then you move your eyes to the next target, then the head, then you go back the other way, eyes, head, eyes, head. And so when we have folks who have little or no central VOR central programming, this is one of the ways that we work on maintaining gaze. And then one of the other last classifications with our gaze stabilization is these remembered targets. This is where you have your eyes on the target, you're closing your eyes, turning the head, and keeping that eyes where the target was, trying to remember where it was. And what this does is that it taps into using some of our cervical inputs to help generate some of the eye movement and keep us on target. Then we have our habituation class of exercises. This is essentially where we're looking at repeated exposure to stimuli that are provocative for individuals, and working on reducing the person's response to that treatment. These go back to Cawthorn and Cooksley back in like 79, 80s. So essentially what we're trying to do is we're trying to kind of desensitize that symptom. We're trying to do a reduction of their response to this noxious stimuli. And so we can look at and figure out, and there are scales for us to use to look at specific movements and what triggers it in order to create our treatment plan. Essentially, though, when someone needs this habituation work, it's really just trying to get people to move around again. You just got to get them going. And then we have repositioning. Obviously, we do our balance and stability training, and then we do repositioning maneuvers for individuals who require that, and that's for people who have BPPV. So just general goals when we have someone who has a hypofunction, a unilateral hypofunction, we're looking at that gaze stability, as I talked about, trying to increase that gain, get those eyes, get the systems online and working more efficiently together. We can look at dynamic visual acuity, which is another test for therapists out there, which look at the first patient's ability to read like an eye chart line, and they do it statically, and they do it with their head movement and head moving. We want to make sure there's not too much of a difference, too much of a change between those two conditions. And we want to work on postural stability, working on normalizing gait, normalizing balance, and returning them to work. That Romberg can be done on compliant surfaces, eyes open, eyes closed, all these good activities. Really fortunate that there are actually clinical practice guidelines that are out there, published in 2016. And this is a screenshot of the sheet from the that summarizes it from the Academy of Neurologic Physical Therapy. And just some of their brief take-home points is that vestibular rehab should be offered for patients with acute, subacute, or chronic unilateral hypofunction, and for bilateral hypofunction. This includes a pediatric population. There's strong evidence that vestibular rehabilitation can improve quality of life, and also can improve the psychological distress that they're feeling. And then in these guidelines, they'll talk about some of the recommendations for the frequency and duration of some of the treatments. This is all, kind of falls on the tail of some of these Cochrane reviews, again, showing that vestibular rehabilitation is safe and effective when looking at unilateral peripheral vestibular disorders. It's more effective than sham interventions. It can help with walking, balance, vision, and ADLs. And interesting that there's one form of vestibular rehab that's more superior to another. Same thing again, that there are gains can be maintained following treatment. And there are individuals who have surgery. So if they may have a acoustic neuroma or a posterior facet tumor that can cause vestibular deficits, we know that vestibular rehab, moderate evidence that vestibular rehab can improve function for these individuals as well. So when we have someone who has a bilateral hypofunction, again, we're working on gaze stability activities and improving our dynamic visual acuity. We work on some rapid gaze shift, moving those eyes around. These guys are really challenging because they oftentimes it's not that both systems are down at 0, but you have this asymmetry. So we want to try and tap into that VOR in order to normalize and create a little bit more symmetry so that they feel a little bit more stable. We want to work on balance, gait, walking, self-care, IADLs, and safety. So safety in these guys can include providing a lot of education as far as making sure that in the middle of the night, if they have to get up to go to the bathroom, they need to turn the light on because their system is not working efficiently enough or effectively enough in order to help them, or that they need to be really careful in the pool and or avoid the pool because they won't be able to orient towards vertical. So really educating these guys about home setup and supports is great. So again, more work that's out here with these guys are that people who do have bilateral hypofunction can also improve with vestibular rehab. You've got Herdman and her group that practiced adaptation. Again, 2007, so they use that adaptation terms of gaze stability and eye head exercises. And they worked on some balance and gait activities, and they showed improvements in all their domains with these guys. They also showed that age didn't appear to be a factor. So if you were older, it didn't mean that you couldn't make gains. You could still make gains in your recovery. And that recovery did occur fairly quickly, so within 5 weeks or so of treatment. Again, Krebs found vestibular rehabilitation was more beneficial than a sham. That sham group just did some isometric and conditioning exercises. And they also used adaptation, which are now gaze stability programs. Brown found the same thing, but in his study, his individuals still had a fall risk. And Tellion took a look at the approaches and basically said that habituation is not the treatment approach to use with this population, that they need more of that gaze stability treatment approach. I do a time check. Okay. So for individuals who have BPPV, we look at, this is that condition where that debris has fallen into the canals. So there are canal repositioning maneuvers. There are lots of them, and they all depend based on the canal that's involved, the location of the debris, all that good stuff. Clinicians also have to take into consideration a person's comorbidities and physical limitations, and might have to modify the technique or choose a different technique based on the characteristics of their patients. And again, really exciting, this is a great read, is the clinical practice guidelines that came out in 2017, where there was a strong recommendation to diagnose and treat BPPV with Dix-Hallpike, diagnosed our posterior canals and our supine roll test to test our horizontal canals. And really interesting, there's a strong recommendation against post-procedural restrictions. So back in the day, it used to be that if you did a treatment, that you would tell the person to maintain vertical for 24 hours, and that is now no longer a recommendation. Needs to be a recommendation. And they strongly recommended also against imaging, testing, and treatment, routine treatment with vestibular suppressant medications. That includes like our meclizines. They recommended against testing basically if there were any signs that were, if there were no signs that were inconsistent with BPPV. So if it looked like BPPV, you don't need to send them out for a CT scan or anything else like that. you can do your positional testing. So that was super cool. So that's a really fun piece that's out there. And then we look at our count and our support for our treatment for these guys and the repositioning maneuvers. And there's great support when we look at the posterior semicircular canal involvement. This is true if we're doing a liberatory maneuver, which is we use for people that have more of a stuck otoconia. And so we saw like the study by Mandela and Chen who found the liberatory maneuver had better outcomes compared to sham. There's weaker evidence currently for treatment of the semicircular canal, but that's also a less frequent diagnosis that we see. So the literature is still growing in this area, but we see that using treatment for it is better than a sham treatment. And then this study by McDonald, they talked about how combining vestibular rehabilitation exercises, some of our gaze stability balance exercises with repositioning maneuvers can improve functional recovery long term. So don't just do their repositioning maneuver and get the debris out, but actually providing some balance and gaze stability exercises. So who can benefit from these guys? The study by Herdman looked at outcomes for that impact individuals with unilateral vestibular loss. Age isn't a factor. It doesn't matter if you're older or younger, that you can still benefit from treatment. And chronicity wasn't a factor. This study that she did had people that had rate of onset of symptoms from 1 week to 12 years. Their median was about 5 months, and there was still improvement that could be made. Comorbidities really didn't impact improvement, with the exception of anxiety and or depression. As we talked about before, some of that anxiety can cause dizziness all on its own. And so they noticed a few patterns of recovery in folks who were rehabbing following unilateral vestibular hypofunction. And those were that people who had complained of feeling worse at discharge generally had a higher anxiety level. And they found that folks who walked around slower at discharge also walked slower initially. And this, of course, was generally our older adults. And then that last pattern that they noticed was that individuals who had worse fall risk scores when they discharged, they were the ones that were falling, who were the big fallers prior to the study. So recovery, again, people can make recovery with this intervention, but some of the bigger challenges for a clinician are when clients have anxiety, when they have migraines, and when they have peripheral neuropathy involvement. Not to say we can't help those individuals, but those are kind of some of the ones that are going to really increase that duration. Lastly, when we look at non-vestibular dizziness, was a really, I really enjoyed this study by Hall in 2010, where they looked at individuals who had dizziness, which they described as symptoms of unsteadiness, spinning, or sense of movement, or lightheaded, when there was no real vestibular sign of it or vestibular origin. And they did this randomized placebo-controlled study. They took their older adults with non-vestibular dizziness. They did a 6-week course of either balance exercises or balance and gaze stabilization exercises. And while both groups improved in all their outcome measures, the group that performed the gaze stabilization exercises had a significantly greater improvement in fall risk as compared to the group that just did balance exercises. So if you're seeing these folks and you're thinking like, nah, I'm doing my balance exercises, throw some gaze stabilization exercises in as well, as we know that this can be extra valuable for this population. All right. I know Stephanie's getting nervous over there. So,
no, I'm not.
Okay, good. So when we look at our treatment team, when individuals have dizziness, it can be the PT or an OT who specializes in vestibular rehabilitation. There's can be an ENT physician on board that might be helping with some of the diagnostic work, and also including neuropsychology or psychology can be really helpful. Again, as I've talked about, I think a few times, is that anxiety component for these individuals that impacts these individuals. And using neuropsych to kind of help with some cognitive behavioral techniques and therapies can be helpful for these individuals as well. Take another sip. All right. So we're gonna bring it home. So we know that people who have dizziness or vestibular vestibular disorders are really common. We can see it at all different ages, in all different environments, but that our incidence does increase as individuals age. So potentially, even if you're working in an environment and treating people with orthopedic deficits, our world's all neurologic, but if you see someone who might have an orthopedic issue, it's not a bad idea to add in some of these vestibular rehab gait stabilization exercises with their treatment. It is safe and effective vestibular rehab for managing a lot of different vestibular deficits. There are a lot more that I did not mention today because it's just so such a large area to talk about. And with vestibular rehab, there's a really high chance of improvement with very low risk of injury or complications. So why not? Why not give it a go? And we know from the literature that our vestibular rehab can make a positive impact on a person's balance, their perception of dizziness, their feeling of dizziness, and then that can improve their quality of life. It can get them back to work. It can get them back to doing the things that are meaningful and valuable to them. And so I think, forgot about this. Okay. So I provided some resources. So the Vestibular SIG, or a Vestibular Special Interest Group for the Academy of Neurologic Physical Therapy, has a lot of really great resources. There are resources that are available for clinicians. There's clinician fact sheets, and there's also fact sheets and information sheets for patients. A lot of really great stuff. And then you've got the VEDA website or vestibular.org, which is a really great resource for consumers, for patients, and for clinicians to kind of tap into as well.
On behalf of Bancroft Neuro Rehab, I would like to thank you for attending the webinar. Have a great day.